Please let me know. Can everybody hear? Yes, perfect. I see that some people can hear. So welcome everybody to this webinar. Today we have as a speaker Dr. Carlos Chua, who is connecting from Manila, Philippines, and he will be sharing his experience with the Adaptica products. So we're very glad that he's here today with us. Just a couple of quick information about the webinar. If you have any trouble with video or audio, there's a reconnect button on the right corner above the screen that you can click to resolve any issues you may have. And then for any questions regarding the presentation, you can leave them in the question section below the video. And please not in the live chat so we don't lose them. Also, we have opened a poll in the polls section. So please, if you use vision screeners or not, answer that. And now I will leave Dr. Carlos Chua to his presentation.
So good afternoon. Well, good evening. Good morning to you guys for those that are in Europe, or noontime, I guess. I cannot see my slides. Sorry. There you go. All right. So thank you to Adaptica for inviting me to just talk about how photo screeners have helped my practice. So I see through in the polls that a good probably about 6, so about 15-20% are using photo screeners in their practice. So when I use photo screeners, when do I use my photo screeners? I basically use my photo screeners from about age 1 onwards. It just makes my life much easier. And I'll discuss it with you later on why it does. But basically, like for the age-appropriate methods for pediatric vision screening, this is just a quick one. Usually from age 1 onwards, we can use the vision screeners already, just to check. So when I ask my staff, or when I'm out in a mission and I have to do vision screening, I usually have to use the Snellen, the HOTVs, the Leias, or even Teller or Cardiff cards. And this takes a lot of time. Taking the visual acuity of a child is easier said than done. You get children that will cry. You will get children that will have no response. There will be children that laugh and then start screaming afterwards. There's just so many variables involved when you take the visual acuity. I have parents that actually get frustrated because it's taking forever for my staff or myself to be able to get the visual acuity of their child. So what do we do? So usually, especially for my residents, I ask them, so what do you do when you do your visual screening? So do we pray? Do we sing and dance to entice the children? Do we use videos to, again, entice the children to just look at the screen? Or do we ask the child to come back once calm? I have a lot of patients that I have to have come back, especially when I have to do a vision exam or to do an ophthalmic exam in general. But how can we make this easier for us? We can make it easier for us by using a photo screener. I mean, if you're an ophthalmologist or an optometrist, we already have an autorefractor in the clinic, but this is quite difficult for the younger children to use. I can make 3 or 4-year-olds kneel down in my examining chair and just use the autorefractor, but then kids sometimes don't want to do this. So the American Academy of Pediatrics already recommends instrument-based screening, especially between 12 months and 3 years of age, and about annually thereafter. Same thing with me when I do get my patients from the pediatricians, or when they come for a well baby checkup. I do try to get the vision right away. And as much as possible, if I can get them to read, I would do it. But most of the time, especially in the younger age group, they will be sucking their thumb, they will be screaming, they will be crying, or they will be not answering. So it's quite difficult to understand whether these children have a problem or not. And this is where the instrument-based screening comes into play. So again, the Children's Eye Foundation, the APOS, says that instrument-based screening can be relatively quick and requires less attention for the child compared with traditional visual acuity screening. And it's a helpful alternative, especially in developmentally delayed children. So what do I use in my practice? I started out with the spot screener by Welch Allen, and I'm now using both the Two-Win and the Kaleidos in my clinic and in my practice. So as you can see in my first slide, in the waiting room of my clinic, the Kaleidos is out. The Kaleidos can be used right away for some children before they enter my examining room. My staff will be able to take at least a quick refraction of the children without them having to sit down or put their face something near something huge. So I can, if they're scared, they actually stay outside the door of my clinic. We just bring this cannon, just bring it out so that they can use it from outside, right? Inside the clinic, again, I can use it still inside if they're more responsive. If they can do their visual acuity, I'll make them do their visual acuity first, and I'll use either the Two-Win, the Kaleidos, or my spot screener. Sorry, I'm too quick. Or I can use my spot screener or my Two-Win while examining the patients. So again, here's another view of how I use my Kaleidos. For some of the kids, I can use the AR that you can see at the side. You can actually still see my Kaleidos right in front of the chair. They can actually use it sitting from the chair and they're having fun with that one. Or I can use the spot screener as well. Um, just a view of how the spot screener and now the Two-Win works in my clinic. So the patients are just sitting down calmly and then they're looking at the screen. In a mission setting, we do a lot of medical missions here in the Philippines to the underserved areas. So you will note right away that these are usually done in a gym, in a large, bright space, and with lots of people. So these people are all lining up. These are adults. I do have children on another row, and the Kaleidos is right there. So just a small space. I don't need a huge space. I don't need a dark room for this. Once I do my screening with the Kaleidos, I actually have an optometrist on the other side as well in these missions, and we can actually start refracting or giving them a proper refraction afterwards. So just some photos of the children using the Canon, as they call it. I know it's quite bright, but sometimes, especially if fixation is very poor or it tells me that there's something wrong, there's no result coming out, and you have to check the red-orange reflex, see if there's a cataract or any other problem. Again, for children especially, they like the Kaleidos because they call it the Canon. In my clinic, children are excited to use it because they think it's different. Some want to ride on it, which is the most worrying part about it for me. But it is something that is sleek and interesting to the kids. So most of the time, I will be able to make them use this machine. So again, just more photos. The nice thing with this photo, if you look to the photo on your right, this is a child in a wheelchair. So it's much easier for them to use it as well, and it's not difficult for them to use. I was initially worried about how to screen kids that are mobility impaired, but it works. Of course, if I can't do it with the Kaleidos, I will just bring out the Two-Win and use it as a handheld photo screener. Again, this is a different one. This is the other machine I use, which is basically the spot. So what do I see, or what do we see in the screens? So for the spot screener, for the Welch Allen spot screener, this is basically what you see. It'll either say complete eye exam is recommended, and then I will be able to see the myopia, the astigmatism that comes out. So it's quite huge, like in this slide right here. Again, you might just have a normal exam, which is basically screening complete. The nice thing with the handheld device is you can actually just turn it over and show the parents if their child is normal. Or you can turn it over and then you can show them that the child does have myopia, like the one on the top right, anisometropia, myopic anisometropic, like the one in the bottom right, or a strabismus, which is basically what you see on the bottom right as well. So again, this one is nice, especially it's nice to have a handheld device, especially for the children that come to you with the parents complaining that the children have strabismus. And they're usually just pseudo strabismus, basically because of the epicanthal folds. So when you take a photograph with either the Two-Win or the spot, you will be able to show them that the eyes are straight, right? For the kaleidos and the two-in, basically it comes out like this. So I have two screens coming out. Basically, they'll be able to see in the bottom photos, they'll be able to see the photo of the eyes and the red-orange reflex and the prescriptions that come out. And the nice thing with this is you can actually show another screen which shows them exactly where they failed. Whereas the spot just says complete eye exam and just shows you where the if, whether the red bar is in the myopia or hyperopia or the astigmatism side. Here, you can actually show the parents or the guardians exactly where they failed the screening criteria. And this is a nice thing. This is something nice that the parents really appreciate. Or if you do this in a school setting, the teachers are also nice, appreciative of the fact that they know exactly where uh, the child is having a problem. So, but you have to remember, especially for the children, because when we use a spot screener, when we use a two-in, when we use a vision screener, screening criteria is for children, right? These are the amblyogenic screening criteria. But a lot of us will also be using this for adults in a vision setting, in a mission setting. And sometimes it comes out like this. You'll see that the patient's a 18-year-old with a -1 and a minus 1.50. He came in with complaining of blurring of vision. So when the nurse or the mission staff actually just took the screening with the kaleidos and then they saw that everything was normal, they let the patient go. Luckily, the patient kind of just did a 180, came back to the other side where the kaleidos was, and tapped me on the shoulder and said, "Doc, I can't see." So, but they said it's normal. When I look back at the results, I could see that there's a -1. So you have to take this, especially with the adults who will pass their screening tests if they're just mildly myopic or mildly astigmatic. You have to go and make sure that you check with the visual acuity because these people will be able to do a visual acuity exam. So, like the previous lecture last Tuesday, handheld photo screeners have been found to underestimate hyperopia and overestimate myopia. Um, in my experience, a spot will overestimate my astigmatism, whereas the two-in and the kaleidos actually is much, much closer. And the estimated refraction, you have to remember, especially for those who will be doing it in a mission setting, these are not suitable for final prescription. I'll talk about this a little bit more later because, especially for me as pediatric ophthalmologist, there are times that I may be just having to use this number because of special situations. So these are just the positive predictive and negative predictive values for all the spot screeners available, and they have fairly good sensitivity and specificity. So in my practice, in my clinic, light is a major factor. We've heard this from last week. Dim the lights. We need a pupil size is about 4 millimeters or more. Um, if you're doing this in a mission setting, even in the clinic with the lights on, you will have people with dark irises who will actually constrict even more. So you have to bring down the light, especially if you're using the handheld screeners. In my practice, we do see a lot here in the Philippines of Asians, Chinese descent. Epicanthal folds play a big part. Filipinos or the children here, when we say, "Oh, we're going to have a photograph taken," they instantly smile. And these children with epicanthal folds will lose their eyes, right? So it is something that you have to take into consideration. Third and most important is actually the attention. Attention, attention, attention. Because if the child does not pay attention, no matter how nice, no matter how bright, no matter how colorful your handheld screener is, if they don't look at those lights, we won't be able to get a response, right? In my practice, I may be about a -2, so undercorrected on my hyperopia, about -1 to -2, non-mydriatic. Myopia maybe plus minus 1.5, and astigmatism is close, about a plus minus 2. But in parentheses, if the child is squinting, I actually get more astigmatism. It maybe has to do with the folds, I don't know. But squinting does play a part in my clinic setting. In my practice, it's nice to use these machines in developmentally delayed children. I have children who actually are just about to enter my clinic and they are already screaming, they're crying. They're lying on the floor. So I don't make them go into my clinic. I can stay by the door. They can stay in the hallway. It is bright though, uh, and I can actually just do a quick vision screening, photo screener exam, and I'll be able to find at least something going on. So it's nice for the developmentally delayed children. Again, I always say that in the previous slide that I'm not supposed to use this number as my final prescription, but sometimes, especially for developmentally delayed kids, um, as long as they have functional vision, then it is something that I can use, right? Ideally, for developmentally delayed children, I would use a handheld photo screener, either the spot or the two-in. The next one is nystagmus. 25% of the time, we can actually get prescriptions still with the spot screener or the two-in with nystagmus. 75% of the time, I do. But it is something that you can use, especially for developmentally delayed with nystagmus kids. Um, for those with strabismus or opacity, I can do a monocular testing. We can do one eye at a time, and it is quite nice to use. So, is it useful? In my practice, especially since I do go out and offer my services with the staff for school vision screenings because it is already going to be mandated by law here in the Philippines to do vision screening, it is useful because I can offer it as a screening. Whereas before, I would have to train teachers, nurses to do vision screening for kindergarten or grade one children, and it would take a whole day to do maybe three, four classes of about 60 kids each. Um, with a spot or a kaleido, it's much, much quicker. And the nice thing with this is because once they fail the exam, of course, they come back to you. They either come to the pediatric ophthalmologist, the optometrist, or any healthcare profession that deals with children. So it's something nice. It's something useful for us. When we do medical, surgical, ophthalmic, or optometric missions, again, it is easier than lugging along a huge automated refractor. But of course, automated refractor, because there's care when you're doing cataract surgery later on, that's different. But if you're just doing a purely medical mission without any surgical component, it's much easier to lug along a handheld device rather than a huge machine that needs to be plugged in. Um, for suggestions for me, handheld devices I would much rather use for the younger children, the uncooperative or the scared ones. The kaleidos can be used for older children or the children that are actually inquisitive. Like I said, my patients call it the cannon or the horse, and they would love to use the cannon to take a photo, and then they'll see it in the tablet. I can actually use a larger Android device, so I can use a 6.5-inch Android phone. The When you do get the results, it's quite difficult, so you have to export it as a PDF before it becomes better. Um, my device is now Bluetooth, so it's much, much easier. Whereas before, when it was a Wi-Fi connection, it was quite difficult. When it was still the Wi-Fi, I was just using the two-in, so I could just see the results right away on the screen. But with the Kaleidos, you had no choice. Yeah, so I was so glad that when I did get the Kaleidos, it did come already with a Bluetooth function. So, is it useful again? As an initial screening in the clinic, it is. Like I said earlier, children are inquisitive. They like to use the Canon. It helps them prepare for chair time because they're already using and they're already focusing their attention on that machine. Um, it also identifies difficult patients. If they don't want to do it here, then I already know that I may have to spend more chair time with this child. So it's something that I already can prepare for. It increases my patient load as well, especially for the younger kids. I already have a baseline refraction that I can use before I do my retinoscopy. Um, as a pediatric ophthalmologist, I really do a lot of cycloplegic refraction. So, but I already have a baseline at least. I don't have to be moving lenses left and right. Uh, and the child gets more irritated because I have to keep on changing. I already have a number that I'm looking at, especially for the astigmatism, and it's something easy for me already and becomes quicker for me to refract these children. And I think that's the end of my slide. Thank you. So I hope everyone stays home aside from us. We work so you stay safe and we all heal as one. Thank you. Any questions?
As we leave the people time to write their questions, I would like to thank you a lot, Doctor, for giving this presentation and sharing it with everybody.
Sorry for being so fast
I think it was good.
when I got excited.
Also, if you need any commercial kind of questions, you can refer to the website adaptica.com for the devices. If you need questions specifically, you can ask to the distributors of your country, so you can find information on that at adaptica.com. And on promotions that we might have, you can click on the website. It should appear now in the top of your screen, a page for more information about that.
Okay, so I have a question already from Faisal. So can you use the 2-win as a primary diagnostic to prescribe
Questions?
it?
I don't see.
Yes, in a sense that especially when you are in a mission setting, if they fail the exam, especially for children, then I know right away that I have to refract the child, or I know I have to do cycloplegic refraction. Like I showed you earlier in the initial slide, in one of the initial slides, if you're doing an adult with a mild myopia, you will see the results as a myope, right? For me, myopia is much, much better seen or diagnosed, refracted with the handheld or the kaleidos. But when you come out with the results page, it comes out that they're all green. So you have to remember that if it's a child and they're all green, I'm not worried. I won't give the prescription. But the moment there's an X anywhere, then of course it becomes a diagnostic tool for you to be able to use to do a more proper refraction. So I would probably already start using your loose lenses or using your phoropter uh, to refine the uh, the refraction that was seen in your device. For adults, I would use it, and this only if I also had a Snellen acuity or a visual acuity, because this will tell me exactly where. Then like with the minus with that kid with that 18-year-old with the -1 and -150, he was only getting 20/50, 20/60 on his visual acuity. So it was nice. So because it was in a mission setting, it was easier for us to refine using the loose lenses and give him a prescription in the end. Uh, so Shara, yeah, compare refraction with retinoscopy. Um, is it correct? I think that it is a correct use of this instrument. Yeah. So for me, for the 2-win, I do get good results in terms of my astigmatism, even with the axis. It's much, much easier. It becomes so much easier for me to do retinoscopy because I already have a number to start with and to slowly refine. Um, Hyperopia, again, minus up. It's undercorrected by maybe 1 or 2. So I usually do a cycloplegic refraction anyway, so I'm not worried about that. For myopes, it is quite good, about a -1 to -1.5. My only problem with the astigmatism again is when they start squinting. The moment children start to squint, number one, they don't get the fixation or they don't get the attention. But sometimes it also causes a little bit of a corneal distortion, and it gives me a different astigmatic reading. The 2-win is much better for astigmatism than my spot. My spot gives me a lot, maybe a -1, -1.5 to 2 difference in the cylinder, whereas for the 2-win, it's much, much closer. Okay, so I have one here by Yogesh. Is it show far as well as near power number? Uh, it will give you the distance, because the the 2-win and the kaleidos are basically distance machine. So it gives you a better hyperopic refraction, if especially if the individuals are hyperopic. Reading, of course, it will be different. It will not. So it does show better results even for hyperopia at distance, because even though it is undercorrected, it is much, much uh, lower than the undercorrection you get from the automated refractor, because of the accommodation and the compensation when they are looking at a near object. Sudeksha actually asked the question at the chat: how is the given power different from the autorefractor? Um, there. So it's different more for hyperopes. You will get an undercorrection in hyperopia when you use either the handheld or the kaleidos. but it is much less than when you do it with the autorefractor, because the autorefractor can get you a plano on a child that sees 20/50, but whereas when you have the kaleidos or the two-in, I will get a plus 2.5. So I already know right away that there is a problem on the child. Or when you do an autoref, the autoref will say no target because the child is already an accommodative ISO, and you won't be able to get the results. Whereas when you do it on the or you get a very low hyperopia in an accommodative isotrope in the AR, but the moment you do the kaleidos or the two-in, I will get a higher one. I will get a plus 2, plus 250. Then I know right away that I need to cycloplegic this patient to be able to get the best hyperopic refraction. Leandro, do you try the CR app? Corneal reflex. The Do you mean the like the toggle for the children that have who have very small pupils? Even in a bright situation, I use the CR, those tinted lenses to be able to get a better refraction. But of course, that's something different. Again, children will be having to put something close to their eye, and if you're doing already a handheld, that usually means that these children don't want to have anything close to their eye. So it is. I've not used it yet for my strabismus. I usually still do my prisms for that one, and most of the time I am more comfortable just using it with using prisms to measure uh, my strabismus. I Did I answer your question? So Vanya's asking a question. Do you see differences from the different light for fixation, whether it's the red light or the color light? I always try to do every exam for hyperopia, especially. They like the colored lights more than anything else. That's why it's much easier for me to use the ones with the lights and the sounds. Um, Children are very visual, so they really like the bright lights. So it is something that is important for me to be able to use. But the brighter your lights, though, in a when you do an exam, let's say in the clinic or when you do it in a mission setting, the bright lights affects my refraction in terms of the yield. I will get more no findings. I with the no fixation or poor fixation. Rather, if it's very bright light. So I would if it's the environmental light settings, then it would be better to use the kaleidos, as this would be easier for to block out all the other light. The problem for me with the kaleidos, I asked that question with previous doctor as well. For the smaller kids, and there are some smaller kids that like to use the kaleidos as well. Their faces are very small, so there's a lot of ambient light coming in through the sides, or sometimes their pupillary distance are so close, so the machine doesn't get any reading. So then I have to switch to a two-in to be able to do that to get my results. So I guess depending on if you are an ophthalmologist or an optometrist, if you are an optometrist or you are in the vision field and you do a lot of screening, this is a device, or the photo screeners are devices that are actually going to be so much more helpful to you. You will be able to screen and identify those that need, and those are the ones that will go to your practice. So I think that is the one takeaway that you can, or for those in the industry, that's one takeaway that you can actually tell your customers in that sense. That it is something that you can use, and it's something that will be able to get you your patients in the end. I am in a private practice, so um, I don't really need to see a lot of patients, but then at least if there are individuals or there are groups or schools that want a screening done, then when I do the exams there, I can get the patients that come to me. they come to me to have the refractions done.
Any open ones right now? I just would like to thank you once again, Doctor, for being here and sharing your experience, and thank everybody who is attending for spending this time with us. Again, if you have more questions, you can just write at the webinar at adaptica.com or go in the website adaptica.com, and we will answer any of your questions. And have a good rest of your evening or day, wherever you are. Thank you very much to everybody.
Thank you. Thank you so much. Thank you. Bye-bye. Keep safe.